I remember we were in Calcutta. I don't know how many years ago that was, Prague, but that was, I would say 15 years ago. And I was in the main portion of the meeting, and I presented on robotic-assisted partial knee replacement. And everybody whose name is on the program, all the ROC fellows, and everybody in the audience thought I was crazy. They said, robots will never come to India. Or Indian surgeons are too good, they don't need robots. Or why do Europe and North Americans need robots? And I'm going to tell you this, and I think one of our last delegates were saying, right now, 65 to 70% of every knee replacement done in HSS is done robotically. And osteotomy is a surgery that's just about, really one or two bony precise cuts. Yet we're still using bovie cords and alignment rods. That doesn't make a lot of sense to me. Now we're talking about coronal angles, sagittal slope. Rick will talk about version. I remember Sachin 10 years ago was the first one who taught me about joint line congruity angle. So we have a lot of parameters. We're building a lot of numbers. And we're still using a bovie cord. So my dad used to say, well, his thoughts on navigation would be, and robotics was be, well, it's just like navigation in your car. If you know how to get home, you don't need to use any app to get you home. Well, I've been driving in Mumbai for 25 years. And God damn it, there's a lot of traffic, and there's got to be some other more clever way. And Pune is no different, and I'm sure Delhi or anywhere else, you want to get some guidance. So there's no doubt that osteotomy has to move forward. And the example was, I gave this lecture to our U.S. military. And if anyone's ever used night vision, people know what night vision is in the military, any of you guys? If you put on night vision, you can actually see in the dark. It is profound. It is like the power of God, like letting you see. But when we operate on a 14-year-old girl with a valgus knee, we're going to use a bovie cord to check her alignment. That doesn't seem right. So I do have some disclosures. I am going to be talking a lot about BodyCAD, and they have supported the meeting. And I am a consultant. And we're going to have a session in the afternoon about BodyCAD, or this evening, and Rick's a consultant too. But the reason why my dad was a consultant for J&J for 45 years and Stryker for 35 years, not because he was conflicted, but because he believed in the product and the technology. And that's what I want to say to you. So I want to tell you why I think we need PSI. Why do I think PSI will be superior to the freehand techniques? The versatility of PSI, show you some outcomes data that we've done, and then maybe a case. So why is this the future? Well, we just saw if you ask somebody to break their leg, you better make sure it doesn't stay broken when you're done with the operation. And there are a lot of complications. Osteotomies in the US were not done. And my Asian colleagues, you guys are all better at osteotomies because a lot of you guys were trained outside of the United States where osteotomies were done. They were not done in the US because they're very litigious. It's the highest lawsuit rate of any procedure in the United States. So total knee became very easy. Everyone did total knees. Everyone did total knees on 45-year-olds, and guess what? They stopped working. A total knee is not a great intervention for a young knee. But it's still, an osteotomy is technically demanding. So what my dad did for osteotomy is for total knee is what I want to do for osteotomy. He took a very complicated procedure and made an average orthopedic surgeon procedure. I want to take a very complicated procedure that master surgeons in Germany and Switzerland did for many years, and master surgeons in India have done for many years, and make it an average registrar's operation. And that's called enabling technology. And that's going to revolutionize a number the safety and accuracy of osteotomy, just how my dad did it with the PFC knee. It made a CR, PS knee, a total knee in a box. We want to do an osteotomy in a box. So we want to make this procedure more accurate with digital templating. And I heard you heard from the podium that they all believe, no one's against digital templating. It just makes the most sense. You can do 20 operations on a computer in 30 seconds. We also want to make an operation safer. We don't want to break bones or cut arteries. And we want to be more efficient and very versatile. So really, what is this technology? Well, it's using a 2D X-ray and overlapping on a CAT scan. So it's 2D to 3D mapping. It's much more accurate than just an X-ray. So this is a 3D bone model that's made on a computer. This is a system. There are a lot of systems like this out there, okay? So I'm not saying you have to just use one. This is the one system I use. It overlaps a 3D model on a weight-bearing 2D. Just so you know, a Mako robot does not do that. It just takes a CAT scan. It doesn't overlap the CAT scan on a log-line cassette. So in terms of your joint line congruity angle, it doesn't give you that information. This does. And then once you get the bone morphing, that really the company all does this with AI, you get a much more highly accurate system. And then you are having fun. You're doing surgery on a computer. You can see, where do I want to put my hinge? Where do I want my starting point? How far I want to be from the joint line? How far from the lateral fibula? What am I doing with my tubercle? Do I want to do a single level osteotomy? Do I want to do a double level osteotomy? I can do multiple osteotomies in multiple planes, and I see all my angles. My medial tibial angle, my overall coronal alignment, my joint line angle, my MAD, my LDFA, my MPTA, and I also get all my sagittal numbers. My tibial slope laterally and medially, because slope is actually unique to each plane. And then it kind of walks you through how to do the operation. This is very safe because it actually doesn't use a saw. Saw kills bone. Saw's exothermic. This uses drill bits. And the drill bits are all calibrated, which means that even if you try to plunge, it's not going to let you hit the artery. So the drill bits let the bone heal faster for opening wedge. You do use saws for closing wedge, where you're less concerned about bone healing. But the calibrated protects the posterior structures and other neurovascular structures. And then what it really does is that it reduces your fluoro time dramatically. So it's really an osteotomy in a box. It's very streamlined instrumentation. It's a simple setup. It's efficient. It's reduced overtime. You can also, if you'd want to, this company can make you design your own plate. And you can build your plate. Now, it doesn't matter for most knees, but some smaller patients, it's very helpful. You can make a bigger construct or whatever. So it just gives you highly efficient model. But you can also have an off-the-shelf implant as well. So what's the versatility of PSI? For standard osteotomies, do we really need it? Probably not. But when I want to manipulate slope, it's very hard to do with an opening wedge. When I want to do it with a root repair and miss my root tunnel and not use an anchor but use a tunnel, it's hard to do. When I do it combined with an ACL or a PCL, or when I want to do a double level osteotomy and a more complicated osteotomy. So we've published a lot about this and saying how hard it is to reduce slope with an opening wedge. And you really have to make a small anterior lateral hinge, or you have to really destabilize the posterior tibial bone. To do that, you want to have calibration in your drill bits so my coronal hinge axis is exactly where I want it to put it to be. And I can really manipulate my anterior lateral hinge. Here's an example of in the guide that's made, there's a guide pin for my root tunnel. And it goes right there. So it's really kind of slick. Same idea, in the guide, they can put my ACL tunnel. So with other systems, we would take screws out. And if you think of some systems, they only have 2 proximal screws. You take 1 screw out, guess what? You got not so good fixation. So it just gives you a lot of versatility. And when you deal with really more complicated stuff, double level osteotomy version, I don't want to steal Rick's thunder, it really helps you for more complicated stuff. And what's the one thing that computer technology has every single time? A computer is better than a human hand in any parameter. The implants that we have are made by a robot. Putting them in manually is really hard to do. And this is a study that was just published in OJSM, and basically it looked like, compared to 4 experienced osteotomy surgeons, the alignment parameters of using tibial slope, MBTA, and deviation from wedge height is always better with body CAD. It's always better with computer assistance. And not just it's always more accurate, the spray is always less. And this is true for every robotic navigation paper. So here's quickly a case. A lady with a prior ACL has early medial OA. You can see there, overload of her medial compartment. Here are the parameters. She's about 4 or 5 degrees of varus. Here's what you get. Here's your templating system, where you put the guide, where I want to do the hinge axis. I made a small anterior lateral hinge, so I took a degree of slope out, maybe 2 degrees of slope out here. And I also want to miss my tibial tunnel, so I don't have to take the screw out and I don't hurt my ACL. And this is what it looks like with the guide on, me doing with an osteotome and the ultimate plate. And here's our final construct. So in conclusion, I think osteotomy is really such a great operation because it preserves the bone, it helps cruciates, it can deal with so many advanced deformities. It's now very trendy in the ACL world and the cartilage world. But if you really want to be so precise in all these multiple planes and all these multiple procedures, we need a better system to be more accurate, safer, and more versatile. I think BodyCAD will be your new navigation that's in your car to get you home safely. Thank you very much.